Good morning, everyone, and welcome to the webinar, Take Charge of Your Health, Managing Diabetes Successfully, provided by the Maryland Department of Aging. Almost 100 people are joining us today. We really thank you for being here. I'm Sue Lockenmeyer with the Maryland Living Well Center of Excellence, and our speakers today include Dr. Peters, Ms. Haskin, Dr. Kalyani, and you'll be hearing a little bit more from me toward the end of it. Again, I want to encourage you, please submit questions via the Q&A tab there on your screen. You'll also be able to open your microphone for additional comments and questions at the end of the webinar. We are so very excited to have you here, and I'm going to start by introducing Dr. Sadie Peters. She is the medical director of the Center for Population Health Initiatives at the Maryland Department of Health. She's an internist. She is very interested in preventive health and management of chronic diseases like diabetes and cardiovascular disease. Dr. Peters, take it away.
Good morning, everyone. Thank you for the opportunity to talk with you today. Diabetes and prediabetes are pretty serious health conditions that affect many of us as individuals, or that affect our friends, our family members, or other people we know. We hope that this webinar series will help you and your families have more knowledge about steps you can take to improve your health, but we also hope that you learn more about who could and should help you on this journey. There may be more people, many more people, or types of people than you'd thought about. And the more you know, the more you might be able to do to take care of yourself. Because we live most of our lives outside the clinic or hospital walls, often what we do for ourselves has a far greater impact on our health than what healthcare providers, who really only see us a few times a year, can do for us. But because people with diabetes or people who are at risk for diabetes do need help from healthcare providers and their teams, our discussion today is about the importance of being an active member of your healthcare team. First, I felt it was important to tell you a little bit about diabetes in Maryland. Among the 6.1 million people living in Maryland, there are an estimated 2.1 million adults with diabetes or prediabetes. 1.6 million of those are people with prediabetes, and 90% of them don't know they have it. Over 500,000 Marylanders have diabetes, and it's the sixth leading cause of death in our state. People with diabetes have 2 times more medical expenses compared to people who don't have diabetes. And so if you're someone who has diabetes, this is a pretty burdensome condition. Next slide. The COVID pandemic, it's changed so many aspects of our lives, and people with diabetes have not had it easy. There is evidence of increased risk of hospitalization, the need for treatment in the intensive care unit, and even increased death for people with diabetes who have COVID infection compared to those who don't have diabetes. Next slide, please. So diabetes is a complicated condition that takes years, often decades, to develop, and I know you'll hear more about this process a little bit later on in the webinar today. Often, at least for a majority of people with type 2 diabetes, a person moves through several stages, which we call a continuum. I may start with a healthy weight as a young person, but then I get a stressful job that not only has me sitting a lot and in long hours at work, but also I'm stress eating in a way that I hadn't done before, and I gain some weight. With that weight gain comes changes in how my body handles sugars from the food that I eat. Muscles and other body tissues start to resist using that sugar in the blood for energy, and that sugar, which is circulating throughout the body in the blood vessels, instead of leaving the blood vessels and going into the muscles, stays in the blood vessels, causing the level of sugar in the blood vessels to be higher than normal, though it may not be so high that it causes many noticeable problems. Some people are diagnosed with prediabetes at this stage. The higher than normal blood sugar and resistance of the muscles to using this sugar for energy may last for many years. Over time, though, and with a lot of other changes in the liver, the pancreas, and other tissues in the body, the blood sugars rise even higher and stay high, and we end up on the far right with diagnosed diabetes. Next slide. And diabetes causes harm to the entire body. When sugar that should be absorbed from the bloodstream into the muscles and other tissues stays in the blood vessels, it causes damage to those blood vessels. The blood vessels that supply oxygen and nutrients to the eyes, the kidneys, the nerves in the feet, and the fingers can all be damaged. And over time, you can get blindness, kidney failure, nerve disease, which may be painful or may lead to loss of sensation in the toes and other body parts. Some people, usually those who have had diabetes with very high blood sugars for a long time, may even need to have amputation of toes, feet, or legs. Excess sugars circulating inside the blood vessels can also contribute to damaging the blood vessels that supply the heart muscle with blood and can lead to heart attacks. If the blood vessels that supply the brain with oxygen and nutrients are damaged by diabetes, I might have a stroke. Next slide. If you have diabetes, here's a long list of things to do to help maintain your health. It seems daunting, but if you have a car, you might make appointments for regular oil changes and other maintenance. You put in the right type of gas every time to keep it running well. You try to pay attention each time you back up or are parking in order not to scrape it on curbs or back it into things that might put a dent in your car. In other words, you make an effort every day to protect and maintain your car to keep it running. We do similar things to keep our children healthy or to keep and maintain our jobs. We come to work on time, we check in with our boss, we write the right reports or turn in work by deadlines. None of these things is really easy at the beginning, but we realize that the outcomes are better when we put in more effort. The car lasts longer, the job is more pleasant, and maybe we'll get a raise or a promotion. The same is true for managing diabetes. Doing all these things should not only help me live longer and with better quality of life, but should also prevent me from ending up in the emergency department or hospitalized with a diabetes-related problem. Next slide. So this slide is the most important one of the slides that I have. It lists the 3 things I think are the most important in working with your healthcare team to manage your diabetes. First, expect high quality care and consistently ask for it. Your care team should strive to provide care that's respectful and responsive to your individual needs and values. And you should be the center of every clinical decision. This is a position of power, and I would like to emphasize that every person needs to step into this role and understand that the care is really centered on you. This then brings us to our second point on this slide. Educate yourself about prediabetes and diabetes. The more you know about the current guidelines for screening and preventive care, the more you know about the medications and the purpose of them, the more you know about how to communicate with specialists and how to use technology to help with your care, the better off you will be at working with your care team in making decisions. A lot of information is online, but as the third point on the slide says, you should engage all your providers all the time. Ask questions. Call back after a clinic visit if you forgot to ask about something or if something was unclear. Ask the pharmacist about your medications when you pick them up, or if you notice something you think may be a side effect in one of the medications you're taking. Ask the case manager or community health worker about services that you heard were offered that you may want to explore to help you as you manage your diabetes or prediabetes at home. The more you know and the more help you get, the more you can stay on top of that long list of self-management tasks. You can make a real difference in how you live with your condition. Next slide. So, one other of today's key messages is that people with diabetes are not alone in addressing this health condition. Employers are concerned about how diabetes affects productivity. Health insurance payers are concerned that a large percent of their claims payouts are for diabetes-related illnesses, and as the burden of type 2 diabetes shifts to include younger people, even schools are struggling with how to properly support increasing numbers of students with diabetes. Acknowledging that diabetes impacts everyone and that we need really big, broad interventions to address the burden of this condition, last year, the Maryland Department of Health, in collaboration with a lot of other partners, introduced the Maryland Diabetes Action Plan. The plan relies on everyone's involvement and has strategies and action steps for healthcare providers and health systems, but also for community groups, employers, insurers, and state and local government. We hope you'll take a look at the plan and learn more about how you can get involved. You are not alone in this journey. Sue, back to you.
Thank you, Dr. Peters. Thank you for that wonderful information and the assurance that none of us with diabetes are alone. I'd like to introduce our next speaker, Ms. Danielle Haskin. She is the founder and senior advisor for It Looks Like Me, an organization that specializes in social and structural determinants of health. She's a community health worker and is experienced in working in community with people who have diabetes. Danielle, I'm turning it over to you.
Thank you, Sue, and good morning, everybody. So as we just heard, there's a recurring theme we're going to hear, and that's really having a team to have a successful path. So we're going to talk a little bit about who else is on your healthcare team and some people who may be involved that you may have not considered as essential as they really are. So as we heard, and as we'll continue to hear, that diabetes can affect nearly every part of your body and every aspect of your life. It really does take some lifestyle changes to get a hold of the condition and make sure that we are monitoring it. So a team is needed to approach and address every aspect to maintenance, and at the core of your team, you likely have your primary care physicians or other physicians, an endocrinologist, depending on your stage, or your level of care, certified diabetes educators, and other medical professionals. But what we'd also like to talk about is who else is there. Next slide, please. So just getting started again, we'll look at, in addition to some of the physical or the medical professionals that are available to help you throughout this path, who else should we be thinking about? Next slide. So I'd be remiss if I didn't acknowledge your personal network and the importance of having family, friends, and coworkers involved in your diabetes care. So social support from friends and family definitely has a significant and a positive effect on treatment adherence to help you to stay on track, especially when there's, this may be a new situation for you and we're learning to, break old habits and create new ones. So the support can help people with diabetes follow through on your new treatment plan, possibly ease the stress that's associated with managing chronic condition. And in combination with the healthcare professionals that we talked about before on your team, you'll be well armed to tackle diabetes long term, because this is a long race. They can provide many forms of support that you may be familiar with, just with instrumental support in driving you to your appointments, or even helping inject insulin, but also social and emotional support in helping you cope with the disease. And you'll hear some more about some of those emotional aspects a little bit later. So through communication and attitudes, family members often have a significant impact on your psychological well-being, and even the decision to follow recommendations for medical treatment that you may have received, and the ability to initiate and maintain challenges that you may come with diet and exercise. Next slide, please. So one thing we've heard about a little bit are community health workers. And really, community health workers are people who have a cultural understanding and a background in the community that they're involved with. So some things that they may be able to do to help through, as you see here, screening and health education, potentially outreach and enrollment into programs that will help you manage your diabetes. They should definitely be a member of a care delivery team, patient navigation, and community organizers. So working with diabetes care providers, community health workers can help identify and overcome cultural barriers to self-care or behavioral change. They can make referrals when indicated to providers, specific providers, and accredited or recognized diabetes education programs that are there in your local area. Again, they can provide culturally specific basic health information. So something that may be related to just food education that's culturally appropriate to what you eat, or even in a specific language that you're most comfortable with. We can convey diabetes self-management information and healthcare provider recommendations accurately to someone with diabetes. Again, a lot of times the benefits of community health workers is that we've likely gone through the shared experience. So having an understanding of what technical terms that you may hear and being able to relay that information, but also participating in the evaluation of a program or an agency that's using the clinical practice guidelines, assessing a person with diabetes support systems, and working directly in the healthcare team using basic concepts of behavior change to assist you with your diabetes effective self-management, and supporting you with diabetes in your efforts to make changes in your daily routine. Also serving as a link between you and your healthcare team. Sometimes there are programs that are available in your local community that you may not be aware of. So a community health worker can really help bridge that gap. Next slide, please. So continuing on with some of the benefits of community health workers, I really hone in on this point because it's important that your community health workers is going to have characteristics like the population they serve. They should be from the local area, so they have a really good grasp on what resources are available, what the maybe qualifications or the enrollment qualifications are for certain programs, and they can help navigate some of the questions that may come up. Community health workers are cost effective. They help to maybe find some free resources that are available and ways to navigate those, and reducing barriers to care, again, by helping fill out some of the applications, helping assist maybe with going to appointments, getting treatment evaluations, interventions that engage community health workers for diabetes management. We aim to provide improved diabetes care and self-management behaviors among diabetes patients. So overall, these interventions that engage community health workers have been shown to improve patients' blood sugar control and reduce the healthcare use. So by maintaining the blood sugar control and assisting with individual health behaviors, we can reduce the needs for emergency care. So improvements are also seen for self-reported lifestyle changes, something that may be focused on pre-diabetes diabetes patients in something like the diabetes prevention program. And community health workers possess, again, characteristics that are similar to the population they serve. They can be paid or they can be volunteer, but using community health workers for outreach has been shown to reduce the barriers to care and improve the overall health status. As I mentioned before, traditionally community health workers are members who also have diabetes. Community health workers who are working with populations of who have diabetes they may have diabetes, and they've developed effective self-management skills themselves. So that way they can share kind of the challenges that they found, and they can address some of those questions that may come up. Next slide, please. So where can you find a community health worker? You may be surprised that more than likely you already know a community health worker, and even more so that you yourself may be a community health worker. So they're known by a variety of different names, like, as community health worker, but also complementary healthcare worker, community health advisor, an outreach worker, promotora. There are various names for a community health worker, but it's somebody who's able to assist the community in navigating through a particular situation, in this case, diabetes management. So you may find a community health worker at your church or your place of worship, at a self-management program if you're already enrolled in one. But again, community organizations or faith-based organizations, even looking into your local health department, talking with your doctor or your physician about the benefits of community health workers and if they can refer you to a community health worker, because again, community health workers really are an essential part of your diabetes management team. So I'd like to thank Sue for providing us with the opportunity to talk about community health workers and the benefits. And I hope you really will consider partnering with a community health worker, or even becoming, involved in your self-management program so that you're able to provide information to others, and you yourself being a community health worker. And I'm interested to hear in the rest of the presentation. Thank you.
Thank you so much, Danielle, and what wonderful information. I want to remind everyone that you can use the Q&A to ask questions. Please do. We also have allotted about 30 minutes at the end for you to be able to raise your hand and actually ask a question in person as well. I know it's important to you. That's why you're here. Now, I am so pleased to introduce our next speaker, Dr. Rita Kalyani. Is president of the American Diabetes Association here in Maryland, very active across all parts of that in terms of the state of Maryland. She is an associate professor of medicine at Johns Hopkins, and she is an endocrinologist, again, a real specialist dealing particularly with diabetes. Dr. Kalyani, please go ahead.
Thanks so much, Sue, and thanks to Dr. Peters as well and Dr. Langley for their leadership with the Diabetes Action Plan. It's truly an honor to be able to speak to you all today about what is prediabetes and diabetes. Next slide, please. I have no relevant financial relationships. Next slide. So I'm going to start off by talking just about big picture of how diabetes affects people in the United States. You heard earlier from Dr. Peters about how diabetes affects people in our state here in Maryland. I think it's helpful to know kind of the big picture as well across the country. So currently, more than 30 million people in the United States have diabetes. That's almost 1 in 10 people in our country that have diabetes. And what's perhaps even more concerning is that about 1/4 of these people don't even know that they have it. So you can immediately appreciate the challenge of trying to reduce the burden of this disease and its complications when there are still people out there that don't know that they have the disease. In addition, 84 million adults have prediabetes. And when you add that to those that have diabetes, that's more than 100 million in our country, or 1 in 3 that have one of these conditions. And again, only 12% reported being told by a healthcare professional that they had prediabetes. So as we talk about how we can reduce the burden of this across the state and how it affects people in our state, it's important to recognize that one of the first steps is building awareness and education, which is what we're doing here today. And as you also heard, the total cost of diabetes is very large, and it's estimated at more than $300 billion for the United States. And people with diabetes, as you also heard, have medical expenditures about twice that of their peers, and the costs continue to be increasing, especially as our population with diabetes is growing longer, which is fantastic, but they're also incurring greater costs as well. Next slide. So this slide from the Center for Disease Control demonstrates that diabetes doesn't just affect one racial or ethnic group or affect men or women. It really affects everyone from diverse backgrounds to Asian, to American Indians and Alaskan Natives, to Asians, to Blacks and Hispanics, to whites as well. And you can see that there is some variability, that some high risk race ethnic groups are noted, including those of American Indian or Alaska Native backgrounds, in particular Blacks and Hispanic in this slide. But truly it affects everyone of any race and any sex in this country. And so when we talk about addressing ways to reduce the burden of diabetes, we're really talking about ways to reduce it for all members of our community. Next slide, please. So what is diabetes? What are we talking about when we say that a person has diabetes? And as you heard from Sue, I treat people with diabetes in my clinic as an endocrinologist and a diabetes specialist, but it's important to realize how diabetes is diagnosed. So these are criteria from the American Diabetes Association, and you can see that there are various ways of diagnosing diabetes, and this is used by your healthcare provider to determine where on the spectrum you might fall. So starting off with fasting glucose, which is a blood test taken after having nothing to eat or drink but water for at least 8 hours, a normal glucose level would be less than 100. People with diabetes have a blood glucose level of 126 or greater. And those with intermediate values between 100 to 125 are in the category of prediabetes, which is a category where people don't yet have diabetes but are at risk for developing diabetes. So how were these cutoffs determined, you might ask? And really they were determined based on when risks of complications develop in people with diabetes. In this case, it was retinopathy or eye disease that was found in large trials to increase exponentially after a glucose value of 126. But in addition, we think of other complications such as kidney disease, nerve damage, and heart disease as well. In addition to the fasting glucose, there's other ways that diabetes can be diagnosed. There's something called the oral glucose tolerance test. This is when a 75-gram liquid solution is given to ingest. Women often have this test during pregnancy, and then the glucose level is checked 2 hours later to see how well the body can respond to a glucose load in lowering the blood glucose. And if the glucose is 200 or greater, 2 hours after ingesting 75 grams of carbohydrate, that's considered diagnostic for diabetes. The third criteria that can be used is the A1C. Now, the A1C is an indirect measure of blood glucose. It reflects the proportion of red blood cells in your body that have glucose attached to them, what we call glycosylated hemoglobin. And they reflect average glucose exposure in your body over the previous 2 to 3 months. And so you can see here that the numbers look a little different. They're in percentages because it's the percent of those red blood cells that have glucose attached to them. And if there is more than 6.5% level, then that is considered diagnostic of diabetes as well. So any of these three criteria, fasting glucose, 2-hour glucose, or A1C, can be used to make the diagnosis, and only one criteria is needed, although your healthcare provider will often recheck it just to confirm that it wasn't a fluke, but it was truly an elevated level. You can also see that the same tests are used to diagnose prediabetes with intermediate thresholds, and that becomes important as we talk about ways to assess your own risk of developing these conditions, which I'll talk about in just a little bit. I did want to also just mention that prediabetes, even though it has pre in that word, it is more than a condition that is associated with the development of diabetes over the subsequent years. It is a condition that's also associated with an increased risk of complications such as heart disease. So in itself, it's important to identify this condition and identify people who have this condition so that they can take appropriate measures, primarily lifestyle changes, to reduce their risk of developing diabetes, but also to reduce their risk of complications. Next slide, please. So the American Diabetes Association has many resources for both healthcare providers and for patients. And one of the ones that we use in our practice as healthcare providers is the Standards of Medical Care in Diabetes. And I had the privilege of chairing this committee a few years ago, and it's really the most comprehensive resource that we have with clinical recommendations on how best to offer comprehensive care to our patients with diabetes. So I will be referencing some of these recommendations in the following slides. Next slide, please. So the slides that I will be sharing are from Section 2, Classification and Diagnosis of Diabetes. Next slide, please. So you already heard me talk about how diabetes is diagnosed, and how diabetes is diagnosed is common for all types of diabetes, with the exception of gestational diabetes. And I'll share those criteria later in my presentation. But really, once a diagnosis of diabetes is made, then the question is what kind of diabetes or what type of diabetes is present. There are two main types of diabetes that we talk about, and other minor types as well. Type 2 diabetes accounts for 90 to 95% of the diabetes in our country and worldwide. And this is due to a progressive loss of insulin secretion from the pancreas, in addition to insulin resistance in the body. So what happens is that people who are at risk for developing type 2 diabetes, and I will share those risk factors as well in just a bit, are people who are more likely to have insulin resistance. Insulin is the only hormone in the body that can lower blood glucose. It is produced by beta cells in the pancreas. And when your body is more resistant to the actions of insulin, the pancreas has to work even harder to produce more and more insulin to overcome that resistance and lower blood glucose. But with time, the pancreas is unable to do that. It's unable to compensate for that insulin resistance. And that's when we see decline in insulin secretion and the development of prediabetes, and then eventually diabetes if there's no intervention. This type of diabetes tends to be related to family history, obesity, and other factors such as physical inactivity and diet. Type 1 diabetes accounts for up to 5% of diabetes. It is due to a very different mechanism. It is due to autoimmune destruction of the cells that produce insulin, beta cells. And when we say autoimmune, what we mean is that the body does not recognize the pancreas, but specifically the beta cells, as being its own. And it attacks those beta cells as if it would attack an infection or a foreign invader with antibodies that effectively, inappropriately destroy the insulin-producing cells. This usually leads to the need for insulin treatment right away because those cells that produce insulin are destroyed from the beginning, and lifelong treatment with insulin therapy. Type 1 diabetes used to be called juvenile onset diabetes. Type 2 diabetes used to be called adult onset diabetes, but we no longer use that terminology because we know that people can develop autoimmune type 1 diabetes in adulthood, what we call latent autoimmune diabetes of adulthood, or LADA. And we also know that children can develop type 2 diabetes, and unfortunately with the rise of pediatric obesity that we are seeing in our country, this is unfortunately becoming more common. And so type 1 diabetes and type 2 diabetes are the preferred terms that are used. I'll talk about gestational diabetes in just a little bit, but this is diabetes that is diagnosed for the first time in a woman who's pregnant during her second or third trimester after she has that oral glucose tolerance testing. And then lastly, there's other less common forms of diabetes, such as genetic forms where it's one genetic mutation that's been identified, what we call monogenic diabetes syndromes, or maturity onset diabetes of the young, MODY. There's also diabetes that's associated with other conditions such as cystic fibrosis and pancreatitis. And there is also diabetes that can occur in association with certain medications such as steroids, or after organ transplantation with the use of immunosuppression, or with certain medications used in the treatment of HIV/AIDS. So there are many different types of diabetes, but I hope that after this presentation, you can appreciate that type 2 diabetes really accounts for the vast majority of diabetes in our country, and does have some modifiable targets that we can use to reduce its development. Next slide, please. So what are those modifiable targets or risk factors that we screen for in identifying who might be at risk for diabetes or prediabetes? Well, as healthcare providers, we screen people or test people for these conditions if they're overweight or obese. That's a body mass index of greater than 25 for most people, except for Asian Americans, for whom we choose a lower threshold of greater than 23. And in addition, they have any of these other risk factors for developing type 2 diabetes. These include a first-degree relative with diabetes, that's a parent or a sibling, or some cases even a child who might have developed diabetes before the parent. High-risk race or ethnicity, and you can see those listed there as well. Anyone with a history of cardiovascular disease, high blood pressure, or cholesterol abnormalities would also be screened. And then women who have a history of polycystic ovarian syndrome, because that's a condition associated with insulin resistance, or anyone with physical inactivity would also be considered as candidates for screening. And of course, anyone who's had prediabetes diagnosed before should be tested yearly for diabetes. And any woman who was diagnosed with gestational diabetes has a 50% lifetime risk of developing diabetes and should be screened every 3 years. Everyone else who do not have these risk factors, as a general population, it's recommended should be tested beginning at the age of 45 years, and if results are normal, repeated at 3-year intervals. Next slide, please. So the American Diabetes Association has a very easy risk task that you can do on your phone, on your computer. The website is listed here, and it basically guides you through questions. As you can see on the right, how old are you? Are you a man or woman? If you're a woman, did you have a history of gestational diabetes? Do you have a mother, father, sister, or brother with diabetes? Have you been diagnosed with high blood pressure? Are you physically active? And then what is your weight category? And then based on your answers to these questions, if you have scored 5 points or higher, you may be at increased risk for having type 2 diabetes or even prediabetes. And that would be a reason to talk to your healthcare provider about whether you should be tested. And this is a free risk test that can be accessed at that web link on the screen. Next slide, please. So for women, there are different criteria to screen for gestational diabetes. It's not important to know the numbers or the cutoffs that are listed here, except to know that the testing is a little different because of the risk of high blood glucose levels, not only to the mother, but the fetus. The cutoff levels are a little bit lower. Next slide, please. And then, as mentioned, women with a history of gestational diabetes should have lifelong screening for the development of diabetes or prediabetes because of their increased risk, at least every 3 years. And it is recommended that they should also have lifestyle interventions such as physical activity recommendations and dietary changes, and or metformin if appropriate, to prevent diabetes. Next slide, please. So here are some patient resources that can be used by you. The American Diabetes Association has a wealth of resources on diabetes.org, and I encourage you to navigate this site. There's excellent information there. We also at Johns Hopkins have developed a website with funding from a foundation called the Franny Foundation, and the website is listed there as well, hopkinsdiabetesinfo.com. And we have a series of videos in different languages and also a diabetes glossary and a nutrition blog that may be of interest. In addition, there's many print resources out there as well that you, I'm sure, are familiar with or may have seen. And I encourage you to really find the best way to learn that you find appropriate, so that this information is information that can be used to guide the management of diabetes at home. Thank you so much.
Dr. Kalyani, thank you so much for an incredibly basic, helpful information. We did just get in the chat, and I want to make sure that, or in the Q&A, I want to make sure that you answer this now while it's on people's mind. And that is, why does polycystic ovarian disease present a greater risk?
That's a fantastic question. So polycystic ovarian disease in women is associated with insulin resistance. And in fact, many women who are diagnosed with this condition are treated with metformin, depending on their future plans for pregnancy or not. So it's a condition associated with insulin resistance, and it is associated with the development of prediabetes and diabetes as well at a rate higher than the general population. And so it's very important for these women to be aware that they could be at a higher risk of prediabetes or diabetes, and to be screened appropriately.
Thank you again, Dr. Kalyani. Your information was basic, direct, and so helpful, I know, to everyone who's in attendance today. By the way, these webinars are being recorded, so you can certainly recommend them to friends and others. They will be available for at least a good month or two on the website, and we can certainly host them for longer than that as well. So I'm up for this next presentation. I am the State Program Coordinator for the Maryland Living Well Center of Excellence. I'm going to keep reminding you to add questions again in the Q&A, but we will also open the phone lines later as well. And go to the next slide. So certainly we heard a lot about the challenges of diabetes, and it's hard enough by itself, but what if you've also got other chronic illnesses, have chronic pain, if you're feeling depressed, sad, isolated, if you're concerned about falling, you're unsteady on your feet, and you may well be at risk for malnutrition over and above your diabetes issues. And perhaps there's someone, you or someone in your family, experiencing forgetfulness or memory loss. So I wanted to just speak briefly about all of these and resources for you for these additional conditions as well. Next slide. So this is just an array of the programs, evidence-based healthy behavior programs that we have across the state of Maryland. Most of them are available many places. And right now, of course, many of them are available as virtual programs as well. So things that you could easily do from your home. So I'll go into a few of these, and next slide. So again, some of the resources, as I said, evidence-based diabetes and chronic condition self-management programs. These are programs that run 6 or 7 weeks. They're generally done as a group. So now, these days, they're primarily virtual. Again, with other people and family members of people with diabetes. All are welcome over the age of 18, highly interactive, around learning and being able to talk with others with similar problems. Chronic pain self-management is another one that's really important, and that is one which really does deal with pain as a result of any type of condition. It has a very mild exercise component to it and has been really helpful to so many people, both with diabetes and others. And then our PEARLS Depression Reduction Program. So that's really for depression and social isolation, certainly in this time when we are all socially limited in our interactions. You may be feeling sad or blue or down. And so that's a program that's really helpful in these areas. I mentioned the falls prevention programs. This is actually Falls Prevention Month. And so there we have a number, as you can see: Stepping On, Otago, Enhanced Fitness, Walk with Ease, Tai Chi for Better Balance. All of these are programs that will help you improve your balance and strengthen muscles. And then we have a program called Stepping Up Your Nutrition, which really looks at malnutrition risk and talks also about the importance of recognizing muscle strength in terms of balance, in terms of falls prevention. And then finally, just some additional information that I received more recently about why it's so important to stay hydrated. Next slide. So it was interesting to me to learn that mental confusion, particularly in older adults, has several causes, and the most common one is actually uncontrolled diabetes. Also, of course, urinary infection and dehydration. So when you think about people who may sort of seem off their game or not as responsive, particularly if they're older, it might be really important to take a closer look, especially at diabetes if it's uncontrolled, and that dehydration. Next slide. So again, as we age, there are, not only is our risk of diabetes greater, but we actually lose some of our sense of feeling thirsty. So we sort of stop drinking fluids. It's part of the natural aging process. Well, we might look healthy, but we certainly can have an inability to perform normal tasks, and we have lowered chemical functions in our body that can do more damage. So regardless of your age, I want to encourage all of you to really get into the habit of drinking more liquids. And remember, yes, of course, we think about water, but juices, teas, milks, soups, and then all of those fruits like watermelon, other melons, peaches, pineapple, oranges, tangerines, all of those have liquid in them. So again, really important in terms of replenishing liquids. In fact, the recommendation for older adults is to, and probably everyone, is really to drink some type of liquid every 2 hours. And if you are a family member, just, an alert here is to really constantly offer fluids to older adults. And if they're rejecting them, if they're irritable, breathless, or display a lack of attention, these are recurrent symptoms of dehydration. So you may want to turn to the doctor for some additional resources. And so next slide. So I always think it's so important when we talk about all of these resources and people who have accessed them to be able to provide some examples of people who've really had and experienced differences by going to one of the workshops, whether it's pre-diabetes or diabetes or something else. So I wanted to share briefly a couple of stories with you. JW started a diabetes self-management class. You can see his A1C was 9.8, weighed 372 pounds. He reported when he got back after going through the workshop, when he saw his primary care physician, that his A1C is now lower, his weight is lower. And I love this statement. I have followed and applied with the warden. That's what he calls his wife. And if you are a family member of somebody with diabetes, we oftentimes get accused of sort of being the police person, right? But in this particular case, I think he's holding his wife in high regard. So he learned in the class and had really great results. And you can see he's got his own goal of an A1C less than 7 and reducing his weight to 300 pounds or less. So again, just a great example of somebody who has gone through one of the programs. And next slide. This one's kind of hard to read, so I'll read it to you. As my husband and I make these changes in our life, we know it's for the best to achieve a happier and healthier way of living and managing diabetes. We hope in time we can reduce the medications we currently take and hopefully avoid any further complications with our diabetes. As we made a change in our eating habits, we've included our pet dog, Woody, as part of the action plan. Like us, he needed to cut out his favorites, the sweets, pop snacks, and potato chips. He's now enjoying green beans from the crock pot and loves steamed broccoli and tender carrots. He really loves his vegetables and turkey breast and chicken. So it'll add more years to his life too, and set a good example for him to follow as we make better choices. Thanks a million for listening to my positive and healthy changes I am practicing each and every day. I hope these stories are an inspiration. We would love for you to share stories with us and to put things in the Q&A. I see we have one thing in the Q&A now. Oh, we did answer that one. That's about Dr. Kalyani addressed it earlier. So I think with this, I'm going to ask all of our speakers to please unmute their microphones and turn on their audios. Oh, we have one more slide. There you go. Okay, just a reminder that there are 2 more webinars in this series, which are great. They're coming up same time, same place, right? But one is next Wednesday and then the following Wednesday. Again, resources and services to help you manage diabetes. New solutions, we're having a pharmacist and other components on that last one. So we encourage you to register for those as well. Great, thanks very much for that reminder. And we can go, I think, to Q&A. So if you have a question, by all means, you certainly can go ahead and raise your hand. We're happy to be able to actually go ahead and answer any questions. But while we're sort of waiting for those of you who are here to think about that, I'm going to ask that we may have some information, additional points that some of our presenters have. So I'm wondering about Dr. Peters, Dr. Kalyani, and Danielle, if you had things you'd like to share at this point.
I can actually share a few things. We've all made points that there are many other people in the available to help people who have diabetes and or are at risk for diabetes or who have prediabetes. And I do want to emphasize that all of the people who can help are very, very willing to help. We know that in the clinic setting, there are a lot of people who are very knowledgeable, from the medical assistant who takes your blood pressure as you go, as you start the clinic visit, to the nurse who might help you with some more specific education about your medication or about how to use a particular insulin pen or something like that. But there are so many others, and again, I want to encourage people to think about the community pharmacist at CVS or Walgreens or wherever you go, and use them as resources to help you gain more knowledge. Because the more you know and the more you can ask questions about your care plan, the more you can do to actually keep yourself healthy and extend your life as a healthy person, whether you have diabetes or whether you have prediabetes and you're trying to make that situation better.
Thank you. Dr. Kalyani, any additional thoughts?
Yes, I think that just echoing everything that's been said already, that diabetes really requires the support of an interdisciplinary team of healthcare providers, nurses, community health workers, dietitians. We're all here to support the patient in their journey and really as additional resources for education. And so I encourage all people with diabetes to really make use of that team in their care management.
Thank you. And Danielle, other thoughts from you?
Yeah, again, just to echo everything that's been said, Dr. Peters brought up the, I'm sorry, it might have been Dr. Kalyani, I'm sorry, but the standards of medical care and diabetes. And in that document, it mentioned that some of the tailoring treatment for physicians would be beneficial to assess the social context, including any potential food insecurities or housing instability and financial barriers. So understanding that there are other things that you are dealing with in addition to managing this new condition. So just incorporating that team and not negating any of those things to making sure that we're successful in managing our diabetes. So you may think of, I have this new thing I have to deal with, but I have other things going on. And as opposed to separating those, really considering all of those in one context and addressing those things at once to be successful.
That's great. Thank you. Thank you. So I will say, if any of you who are watching today have questions or thoughts, if you just go to the Q&A and just put a question mark in, or just hit anything to open, then I'm very happy to open up your phone line, your audio line, so that you can ask a question in person.
Hi there, this is Charlene Adams. Can you hear me?
Yes.
Okay. I understand that some people have an insulin pump. At what stage or when is that introduced to an individual who has diabetes?
It's a great question. Dr. Kalyani, would you answer that for us?
Sure. So that's a great question. So insulin pumps are small handheld devices that are either attached to a person's abdomen or another part of their body, such as their thigh or their upper arm, sometimes even the buttocks, and delivers insulin continuously through a small catheter that goes under the skin. And really, those devices are reserved for people who are on insulin therapy alone. And so people with type 1 diabetes who are on multiple insulin injections may be offered the option of being on an insulin pump if they prefer. People with type 2 diabetes that are on what we call basal bolus insulin, they're on multiple insulin injections a day, could also be offered an insulin pump. But by and large, it's more commonly offered for people with type 1 diabetes, or even people after surgical removal of the pancreas if they need to be on insulin treatment as well.
Great question. So it looks like you can just unmute your own microphone. If there are others, questions or stories you would like to share, your own experiences in dealing with diabetes or family members, we would love to hear from you.
So if they raise their hand.
I'm looking for that.
They need to raise their hand in order for us to unmute their microphones.
Okay.
Okay. Well, I have another question.
Great, please go ahead.
Yeah, it's very interesting. I've been attending an endocrinologist, and my insulin is being adjusted, but by hearing about the polycystic ovarian disease, I haven't been diagnosed with having it, but my daughter has. And that makes me wonder, do I have it as well? I'm thinking that maybe I passed it to her. So if I pass it to her, then possibly that I have it as well. And so I'm wondering if that's been one of the reasons that my insulin has been changed so often, because that hasn't been considered, having the polycystic. You did say that it was insulin resistant. People who have it are often have insulin resistance, if I said it right.
Yes, that's correct. Polycystic ovarian disease can be associated with diabetes. If one family member has it, it doesn't necessarily mean that another family member has it. But certainly if you have polycystic ovarian disease, in addition to type 2 diabetes, it's possible that your insulin resistance might be higher, and that you might require higher doses of insulin. So usually the healthcare provider should screen for any symptoms of polycystic ovarian disease if they're concerned.
Great, thank you. And a couple of questions have come in. There will be a link for the recording. You will get that, and as we end this recording, you will have a post survey. We want you to take that in the evaluation. Put down your thoughts, your needs. What is it you're still missing that's important to you to have, that we didn't talk about in this webinar? And then I have another question, and that is from Arlene, and she says, I'm the only one in my family with diabetes, and I am obese, but I take metformin, but I need help and more information on this disease. Some ideas from our panel about where she can go for more help.
So I'm happy to start off. So yes, I applaud you on recognizing that being educated is very important. And as we talked about, family history is only one part of the equation that accounts for about 40 to 50% of the increased risk. And the other component are factors such as weight and lifestyle and other considerations as well. So I encourage you to look at some of the resources that the American Diabetes Association has online. We have a section on the different medications for diabetes as well on the website, Hopkins Diabetes Info. There's a lot of good resources out there, but being educated it is your best way to really move forward.
Great. Dr. Peters, do you have more information you'd like to share here in terms of resources where Arlene might go? You might be on mute.
Yes, there we are. The Maryland Department of Health also has a website called behealthymaryland.org, and that's all one word, all made into one word, behealthymaryland.org. It is a pretty reasonable source of simple information about community resources that are available depending on where you are. And there are links to places where you can find classes, some of the classes that Sue talked about, some of the classes that Danielle referenced, and more information about the risk testing that you could take or share with friends. That also comes from resources that the American Diabetes Association has offered to us as well. So there's information there, and there are also links to some of the national organizational websites like the Centers for Disease Control, where you can get more general information too, and again, educate yourself about diabetes. Please reach out. It's really important to us, and that's why we're doing these webinars, to have more people engaged in the conversation for themselves, as well as to help garner support or gain the support that they need to have their families support them. I don't know if that sounds reasonable, but when I reach out for something that I need, I want to sort of bring that information back to the people I live with or the people who are interested in listening to me with my health journey, so that I can share that information with them and they can then use it to help support me in my journey. So please reach out, because everyone does better when they have support and when they don't feel alone and when they feel others understand what they're going through, and when others are asking about how they're doing and looking to see if they're doing better or helping to lift them up if they're not doing better. So do reach out. There are many, many resources, and we are interested in your health. So please call us, email us, send us, a smoke signal if you need to. The American Diabetes Association is a great resource, but all of the resources that we've talked about today are also pretty amazing.
Right. We're going to be talking more with folks from the Maryland Department of Health in terms of the Be Healthy website and what all is on it, how you find things there. And also our Maryland Living Well website has a lot of this information. I can really tell you from experience, because I've done a lot of trainings and a lot of these programs, and I know that so has Danielle, that when you are able to be in a workshop with other people who are going through similar things, it makes a difference. And you do problem solving and other ways of connecting with folks to really make meaningful choices for yourself. And you have that support of the group. So again, really important. And I agree with Dr. Peters, speak up wherever you are. That's really tremendously important.
Yeah, I'd like to just add to that. I've worked with a few people who were kind of embarrassed about the diagnosis and, wanted to hide it. And once they kind of addressed it and did speak up, it's important that they, that you're also able to engage and advocate for not only your health, but the others around you. So as Dr. Peters mentioned, you being involved are kind of able to connect some of the dots. There may be some things that, that the people around the table, for an example, are not thinking of. They may not be directly involved. So by you being involved in some of those conversations, you have a direct tie to what's going on with you and what you're hearing. So you're advocating for things that you need. Likely you're advocating for other people also.
And Dr. Caliano, I think this one maybe is for you. It's from Mary. She says, I have ulcerative colitis and acid reflux over 30 years. I was diagnosed with type 2 diabetes approximately 2 years ago. Is there a website or something that deals with diet specific for people that have an IBD and diabetes? Roughage is horrible on my stomach.
So thank you for that question. It's true that in addition to diabetes, there are many other comorbid conditions that can be present, and that may require special dietary recommendations as well. And so many dietitians would be adept at addressing dietary restrictions for multiple conditions. One of the ones that we see commonly in type 1 diabetes is celiac disease, for instance. And so, dietary management for both type 1 and celiac, but as you mentioned, also type 2 and inflammatory bowel disease. So I would encourage you to talk to your dietitian and to see what resources are out there specifically to give recommendations to address the multiple considerations that need to be addressed.
That's great. And I can share with you that on our third webinar, we have registered dietitians on that, nutritionists. So stay tuned. Make sure you come to that one and be prepared with that question again, because we have a great team from Tidal Health that's going to be talking about the work they do in community. And I think you will learn from them, and absolutely more information to share if you're not in direct contact with an RDM. Other questions from the group, other thoughts from our incredible panelists? I want to thank you all. You've really provided incredibly important, approachable information for all of us, really thought-provoking information for us today. I want to remind all of you who have attended to please complete the brief survey. Let us know what else you need. That's why we're doing this. And we do have certificates of completion for you if you're interested. Happy to give you a certificate to show that you've been attending this webinar. We're so grateful to you for being here, and we are so thankful for the speakers. Anybody have closing remarks?
This is Shirlene again. I just want to tell you that I've really enjoyed each person and what you have presented today.
That's wonderful.
Since I'm going through this a struggle, don't want to call it a struggle, but just managing, trying to get my diabetes managed, it's just welcoming to hear different things that you've pointed out for me to also consider and share with my doctor, question my doctor about it. You know, maybe something that may not have considered, but I wanted to have things managed better within my life. And I just want to thank you.
Oh, thank you for sharing that. And you know, one of the, it's as much of a challenge as it is for us to deal with not being able to see our clinicians in a normal way much of the time. What I have found with the telehealth visits is that the provider is there in a conversation with you, listening to you. It's really a different approach. It's true, you're not getting that hands-on diagnosis, but oftentimes when we go to see our primary care provider, they're busy putting things into the computer. They're talking to us, but you know, they're mostly sort of filling out their forms. But when we have telehealth now, it really is a dialogue. I've seen it a number of times with my husband and some complications that he's had, and having somebody listen and respond, just as our incredible panelists have done today, because they care very much about your health and want to help you on this journey. So we thank you all very much for attending. We look forward to seeing you on the next one. And please do take charge. Thank you.
Thanks again.